Hello, dear students and friends. In my lecture series, the next is part 2 of my video lecture on cancer cervix, a bird's eye view. In this, I would be discussing the various management options. So, in brief, let us see the essential highlights of the various treatment options. Well, management options include surgery, radiotherapy, or chemotherapy, or a combination of them. First, considering the surgical management. Now, disease could be microinvasive disease, in which the diagnosis of stages 1A1 and 1A2 is made on microscopic examination either of a cone biopsy specimen or a specimen obtained by LEAP or cold knife conization, especially the ones which include the entire lesion. It can also be made on a trachelectomy or hysterectomy specimen retrospectively. The depth of invasion in all such cases should not be greater than 3 or 5 mm, respectively, from the base of the epithelium. However, the horizontal dimension is no longer considered in 2018 revision of the FIGO classification because it has not been shown to impact survival. A note must be made always of the lymphovascular space involvement, though it does not alter the stage but may affect the treatment plan. The margins should be reported negative of disease, and if the margins of a cone biopsy are positive for invasive cancer, the patient is allocated to a higher stage, which is 1B1. So these are the two stages, 1A1 and 1A2, which are included in microinvasive disease. Now let us look at invasive disease. In all cases of visible lesions, a punch biopsy is generally taken and would be suffice for diagnosis. But if not satisfactory, a small loop biopsy or a cone may be required. However, for allocation of any staging, we all know that clinical assessment is the first step. But in FIGO 2018 staging, this permits using any imaging modality according to available resources such as an ultrasound, a CT, MRI, or PET, so that it can provide additional information on tumor size, nodal status, or local or systemic spread. MRI is the best method for radiological assessment of primary tumors greater than 10 mm. However, ultrasound at times may be useful. It does have good diagnostic accuracy in expert hands. Now, in areas where there's high prevalence of tuberculosis and inflammation, especially HIV endemic areas, we may find large lymph nodes, and these lymph nodes may not necessarily be metastatic. So, the clinician may make a decision on imaging or, when possible, through fine needle aspiration or biopsy to exclude metastasis and allocate a lesser stage. This is especially true in advanced stages where surgical assessment of para-aortic lymph nodes by minimal invasive surgery or laparotomy may be used to tailor treatment according to the extent of disease. Surgical excision of para-aortic lymph node involvement has been reported to correlate with better prognosis than radiological exclusion alone. Now, FIGO no longer mandates any biological investigations, biochemical investigations or investigative procedures. However, in patients with frank invasive cancer, chest X-ray and assessment for hydronephrosis with a renal ultrasound, CT or MRI should always be done. Bladder and rectum are evaluated by cystoscopy and sigmoidoscopy only if the patient is clinically symptomatic. Otherwise, we can rely on findings of CT or MRI. Cystoscopy is also recommended in cases of barrel-shaped cervix in which there is endocervical growth and in cases where growth has extended to antevaginal wall because we want to rule out any bladder involvement. Suspected bladder rectal involvement should be confirmed by biopsy and histological evidence. Bullous edema alone does not warrant a case to be allocated stage 4. Now coming to surgical management. We know that for early stages, that is up to 1B, surgery is suitable. It could be cervical conization, simple hysterectomy, or radical hysterectomy, depending on the stage of the disease. However, in some selected cases, like stage 4A, in which the disease is limited, in those cases, pelvic exenteration may be done. Pelvic exenteration is a surgery to remove lower colon, rectum, and bladder. The cervix, vagina, ovaries, and nearby lymph nodes are also removed, and artificial openings, that is stoma, are made for urine and stool to flow from the body to a collection bag. Plastic surgery may be needed to make an artificial vagina after this operation. So, this is an exenterative surgery. If we look at the types of radical hysterectomy, it could be type 1, 2, 3, or type A, B, or C. If you look at type 1, which is a simple extrafacial hysterectomy, indication is stage 1A1. Uterus cervix are removed. Removal of ovaries is optional. Vaginal margins are not to be removed. Uterus not mobilized. Cardinal ligaments are divided at uterine and cervical border. Uterocycle ligaments are divided at cervical border. Urinary bladder is mobilized only up to the base of the bladder. Rectum is not mobilized. And the approach in all such cases of radical hysterectomy could be laparotomy or laparoscopy or robotic surgery, depending on expertise of the surgeon. The second, type 2, is modified radical hysterectomy, which is done for 1A1 with lymphovascular space invasion and 1A2. The same thing, uterus cervix are removed, ovaries may not be removed, but vaginal margin of 1 to 2 centimeters has to be removed. Ureters are mobilized from the tunnel in which they go through in the broad ligament. Cardinal ligaments are divided more laterally, where the ureter transits the broad ligament. Uterosacral ligaments are partly removed. Urinary bladder is mobilized up to the upper vagina, and rectum is mobilized below the cervix. The root surgical approach remains the same. Now let us look at what a radical hysterectomy means. It is a type C hysterectomy done for stages 1B1, 1B2, and selected cases of 2A. In this, more part of vagina is removed, upper 1/4 or 1/3. Ureters are mobilized. Cardinal ligaments are divided at pelvic side wall. Uterosacral ligaments are divided near sacral origin. So a majority portion of parametrial tissue or broad ligament is removed. Rectum is mobilized below the cervix, and the surgical approach remains the same. So these are the various types of hysterectomies which can be done in early stages. Now for FIGO stage 1B2 and 2A1, surgery or radiotherapy are the primary treatment options. Both have similar outcomes, and choice depends on patient factors and other local resources. If you look at the advantages of surgical treatment, it is feasible to determine the postoperative stage precisely on the basis of histopathological findings, thereby enabling individualization of postoperative treatment. With surgery, it is possible to treat cancers that are likely to be resistant to radiotherapy, and in these cases, always it is possible to conserve ovarian function. Intraoperative transpositioning of ovaries high in the paracolic gutters away from the radiation field is also feasible. Preservation of ovarian and sexual function makes surgery the preferred mode in younger women. However, surgery in these cases, a type C radical hysterectomy is the standard procedure. Pelvic lymphadenectomy is also an important component. The tumors that are larger, in them, the likelihood of high risk factors such as positive parametria or positive surgical margins may increase the risk of recurrence, and these cases may require adjuvant radiation after surgery. Other risk factors that increase the risk of recurrence even when nodes are not involved, include large tumor size more than 4 centimeters, presence of lymphovascular space invasion of outer one-third of cervical stroma. In such cases, adjuvant whole pelvic irradiation reduces local failure rate and improves progression-free survival compared to patients treated with surgery alone. However, this dual modality, that is initial surgery followed by postoperative radiation, increases the risk of major morbidity. Therefore, the treatment modality must be determined based on availability of resources, tumor, and patient-related factors. Concurrent platinum-based chemoradiation is the preferred treatment option for stages 1B3 and 2A2 lesions. In areas where radiotherapy facilities are scarce, neoadjuvant chemotherapy has been used with the goal of downstaging the tumor to improve radical curability and safety of surgery and inhibition of micrometastasis and distant metastasis. So, where radiotherapy is not available, you can give neoadjuvant chemotherapy and then operate. Now, FIGO stage 4 or cases in which there is local recurrence. Rarely, patients with stage 4 disease may have only central disease without involvement of pelvic sidewall or distant spread. So, central disease means either the bladder is involved or a portion of rectum is involved. In such cases, or in cases of recurrence in which central recurrence has occurred involving the bladder and rectum, pelvic exenteration can be considered an option, but again, as it has been mentioned, it has a poor prognosis. Stoma, the bladder is also opened outside, or the ureters can be implanted into the sigmoid, and at times the rectum is also opened outside, a stoma is made. So now a flowchart for the management of early stage cervical cancer, that is up to 1B. First, identify the clinical stage. If it is 1A1, see whether there is lymphovascular space invasion on initial biopsy, and if margins are positive. If none, it means everything has been removed in the initial specimen. No further treatment is required. However, if there is lymphovascular space invasion, she may require modified radical hysterectomy with lymphadenectomy. And then, depending on intermediate or high risk factors, she may require either adjuvant therapy or concurrent chemoradiation. Now, if after hysterectomy the margins are positive, then repeat coronization or do a simple hysterectomy. Again, identify risk factors and give chemoradiation or adjuvant therapy. Stages 1A2 always require modified radical hysterectomy with lymphadenectomy. Stages 1B1 and 1B2, they also require radical hysterectomy with lymphadenectomy, that is type C or type 3. Again, depending on risk factors, may require adjuvant therapy or concurrent chemoradiation, may or may not require. So that was the surgical options. Now coming to radiation management. I know it is a wide field and a big field in radiation oncology is a big field in itself, but I would only be discussing some salient points which are essential for clinicians so that they can counsel patients and so that the knowledge would be sufficient for future treatment and planning. In low and middle income countries, the majority of patients present with locally advanced disease where surgery plays a limited role and they require radiation. Over the last 2 decades, development of sophisticated planning and delivery techniques and introduction of computer technology and imaging have galvanized the practice of radiotherapy, resulting in improved clinical outcome and reduced toxicity. Apart from its curative role, radiotherapy can also be used as adjuvant therapy for operated patients to prevent loco-regional recurrence, although the role of dual modality is discouraged. It can also be used as palliative therapy for alleviating distressing symptoms in patients with advanced incurable disease. Now, radiation for early stage disease, that is stages 1A1, 1B1, 1B2, and some 2A. Although surgery is preferred for early stage disease in cases with those who have contraindications to surgery or contraindications to anesthesia, radiotherapy provides equally good results in terms of local control and survival. The treatment decision is made on the basis of clinical, anatomic, and social factors. Patients with microinvasive disease have been treated with intracavitary radiation therapy alone with good results. Definitive radiotherapy or combined chemoradiation therapy is preferred in patients likely to require postoperative radiotherapy to avoid compounding treatment related toxicity. Now let us see what is adjuvant radiotherapy. Following a radical hysterectomy, post-operative radiotherapy with or without chemotherapy is indicated in patients who have adverse pathological factors, means those who are high risk for recurrence. According to various prognostic factors, patients may be categorized into high, intermediate, or low risk. High risk disease includes patients either who have positive surgical margins or who have lymph node metastasis, parametrial spread, and such patients should be offered post-operative radiotherapy with chemotherapy. Post-operative radiotherapy consists of whole pelvic external beam radiation to cover the tumor bed and draining lymph node areas. A dose of 45 to 50 gray is usually prescribed. Then there's a term intensity modulated radiation therapy. It is an advanced and refined technique of irradiation and has been explored in postoperative setting to reduce toxicity. Then there is a role of vaginal brachytherapy boost following external beam radiotherapy. The role is not much clear, but may be considered in those patients with close positive margins, large or deeply invasive tumors, those having parametrial or vaginal involvement, and those with extensive lymphovascular space invasion. This vaginal cuff brachytherapy is usually delivered by ovoids or cylinders to the upper one-third of residual vagina and should include weekly fractions of high dose rate brachytherapy of 6 grays each, prescribed to 5 mm from the vaginal cylinder or ovoid surface. CCRT, combined chemoradiotherapy, is the standard of care for stages 1B3 and 2A2 disease. This includes external radiation and intracavity brachytherapy. So, along with chemo, we give external radiation and intracavity brachytherapy. These are the tandem and ovoid placements for cervical brachytherapy. Now, for stages 2B and up to 4A, CCRT is considered the standard treatment, especially in those patients with locally advanced cervical cancer, based on the results of large randomized controlled trials that tested addition of chemotherapy to the pelvic irradiation. Once weekly infusion of cisplatinum, 40 mg per meter square, weekly with appropriate hydration for 5 to 6 cycles during external beam therapy is commonly used concurrent chemotherapy regimen. For patients who are unable to receive platinum-based chemotherapy, 5-fluorouracil-based regimes are an acceptable alternative. The combination of external beam radiotherapy and intracavitary radiotherapy maximizes the likelihood of locoregional control and minimizes the risk of treatment complications. The primary treatment of external beam radiotherapy is to sterilize local disease and shrink the tumor to facilitate subsequent intracavitary radiotherapy. Standard EBRT should deliver a dose of 45 to 50 gray to the whole pelvis by 2 or 4 field box technique encompassing the uterus, cervix, adnexal structures, parametria, and pelvic lymph nodes. Although external beam radiotherapy is commonly delivered by cobalt 60 therapy machines, there are some newer machines which are available now. So this figure shows CT scan images with radiotherapy planning in A. Conventional four-field box technique is shown, while in B, intensity modulated radiation therapy planning, normal tissues such as bladder and bowel are relatively spared in this IMRT span. This is a template which is used to identify the site of tumor and the extent of radiation which has to be given. Then there's a term volumetric modulated arc therapy, IMRT, and the volume to be delivered is subsequently adjusted. The field design which is made, the borders are identified in AP fields and lateral fields, and specific amount of radiation is given to each border, to each area. Standard intracavity radiotherapy is usually performed using tandem and two ovoids and a ring, as shown in this picture. Any of the dose-related systems, namely low dose rate, high dose rate, or pulsed dose rate, may be practiced, as all three yield comparable survival rates. The dose is usually prescribed to point A or to high-risk clinical target volume if image-based planning is used. With low dose rate system, a dose of 30 to 40 grays is prescribed in 1 or 2 sessions. With the high dose rate system, various dose fraction schedules are used, employing a dose of 5.5 to 8 grays by 3 to 5 weekly fractions. If intracavity radiotherapy is not feasible, either due to distorted anatomy or inadequate dosimetry, then interstitial brachytherapy should be considered. Now, interstitial brachytherapy includes insertion of multiple needles or catheters into the primary tumor and parametria through the perineum with the help of a template. Due to risk of trauma to normal structures when we are inserting these needles, like bowel and bladder injury, ultrasound imaging, especially transrectal, is suggested during the implant procedure. So this is the template, and this is how needles are introduced from outside, and this is a CT image showing the placement of these needles. Now coming to advanced stages, that is stage 4B or cases with distant metastasis. Presentation with distant metastatic disease is rare and is reported only in 2% cases. Management plan should consider that the median duration of survival with distant metastatic disease is only approximately 7 months. Concurrent chemoradiation may have better response than systemic chemotherapy, with overall and disease-free survivals of 69 and 57% respectively reported in patients with positive para-aortic and supraclavicular nodes. So in cases with advanced disease, concurrent chemoradiation may have better response. There is no role for prophylactic extended field radiotherapy in locally advanced cervical cancer. When para-aortic nodes are involved, external field radiotherapy with concurrent chemotherapy still can be used. Intensity modulated radiotherapy may be used in such patients to reduce toxicity. Now, at times, we see that a hysterectomy has been done and the HPR histopathology report mentions the presence of cancer. So these are cases of inadvertent complete surgery. The role of radiotherapy in such cases: invasive cancer may be found during pathological evaluation of specimen from either a simple hysterectomy, which had been done for a benign condition. Inadvertent simple hysterectomy is considered inadequate surgery for invasive cancer, and subsequent therapy is required in all such cases. In such situation, the extent of disease again can be assessed by PET or CT scan if available, or by pelvic and abdominal CT or MRI scan and chest imaging. The subsequent treatment plan is formulated based on histologic and radiologic findings. So, based on whatever findings you get, subsequent treatment is done. Although in such cases, we would consider postoperative radiotherapy. It has been shown to be beneficial, but the outcome for such patients, even after postoperative radiotherapy, remains very poor, with 5-year recurrence free survival of 49%, and therefore, in such cases, CCRT, combined chemoradiotherapy, is generally added. A few words about comprehensive palliative care. So, all such women with advanced cancer cervix do require palliation. Symptom control is the essence of palliative care and plays a major role in maintaining dignity and especially quality of life. Common symptoms and signs of advanced cervical cancer include pain, pelvic pain, intense pain, ureteric obstruction, which may cause renal failure. There may be excessive bleeding or hemorrhage, malodorous vaginal discharge, lymphedema, and formation of a fistula, vesicovaginal or rectovaginal fistula. Typically, a tiered approach, three-tier approach to pain is practiced. Initially, give low dose minimal drugs with minimal analgesic effect, and subsequently increase the type of analgesia which is being given. Access to oral morphine is improving and is an important aspect of palliative care. The ultimate pain relief could be done with morphine. The availability of home care teams in many regions and involvement of NGOs in this effort can help to minimize the need to transport the patient to hospital and can save costs. In terminal cases, like no treatment cases in which only palliation is required, some patients may require services of hospice facility. Palliative radiotherapy is a short course of radiotherapy and would be effective in palliation of distressing symptoms. Although there is no standard dose fraction schedule, a dose of 20 grays in 5 fractions over 1 week or 30 grays in 10 fractions over 2 weeks is commonly practiced. Patients with severe vaginal bleeding, a short course of external beam radiation may be tried, and if it fails, intracavity radiation can be highly effective in controlling intractable bleeding. The control of bleeding is usually achieved after 12 to 48 hours of radiotherapy. In patients with pain arising from enlarged para-aortic or supraclavicular nodes, skeletal metastasis, and symptoms associated with cerebral metastasis, palliative radiotherapy should be given via larger fractions over shorter periods. Commonly used schedules include large single fractions, 20 gray in 5 fractions, and 30 gray in 10 fractions. Now, many cases of pregnancy with cancer have been seen, though they are rare. At times, pregnant women may come with intractable bleeding, and on examination, you may find a growth on the cervix. These are cases of CA cervix, which then need further evaluation by a biopsy to prove the diagnosis. In such cases, adequate management through a multidisciplinary team is required. The plan must be discussed with the patient and her partner. Broadly, the management of cervical cancer in pregnancy follows the same principles as for non-pregnant patients. If the pregnancy is between 16 to 20 weeks or less than that, patients are treated without delay. The mode of therapy can either be surgery or chemoradiation, depending on the stage of the disease. So you do not have to consider pregnancy, but do immediate treatment. Radiation often results in spontaneous abortion of conceptus if it is being given with the pregnancy in situ. For the late second trimester onward, surgery and chemotherapy can be used in selected cases while preserving the pregnancy. For more advanced cases, impact of treatment delay on survival is not known. In some cases, neoadjuvant chemotherapy may be administered to prevent disease progression, especially in those women who have locally advanced cervical cancer when treatment delay is planned. That is when you want to continue pregnancy to a particular period and then start treatment. In those cases, with pregnancy in situ, neoadjuvant chemotherapy can be given. When the diagnosis is made after 20 weeks, delaying definitive treatment could be a valid option, especially for earlier stages like 1A2, 1B1, and 1B2. And this has not been shown to have any negative impact on prognosis compared with non pregnant patients. Timing of delivery requires a balance between maternal and fetal interest. Baby can be delivered safely between 32 to 34 weeks, depending on condition and depending on the stage. When delivered at a tertiary center with appropriate neonatal care, delivery by classical cesarean section and radical hysterectomy at the same time is undertaken no later than 34 weeks of gestation. The details of my presentation were taken from this FIGO Cancer Report 2021. Thank you. If there are any questions, you are most welcome. I would be happy to answer them. Thank you.